Welcome, Dr. Helen Almond. Can you tell us who you are and where do you work?
Hello, my name's Helen Almond. I'm a PhD doctor at Swinburne University of Technology, which is in Victoria, the state of Victoria in Australia. I teach digital health and informatics to both undergraduate and both postgraduate students. I also work for the Australian Digital Health Agency as a clinical reference lead. Basically, in that role, I advocate for clinical practice in the strategic development of many roles across the pillars of the Australian Digital Health Strategy, the electronic health record, interoperability, safe, secure systems, workforce education, and the like.
Therefore, Helen, what are you saying to me is that clinicians participate at the national level, because in Latin America, usually nurses and doctors, they never know what is the health policy about digital health. Therefore, can you explain some of the mechanism you use as the leader of the clinicians in that work?
Absolutely. Back in 2012, I commenced my PhD studies, my research studies in the area of electronic health records with vulnerable communities across Tasmania, the backdrop that you can see behind me today. And very much it was found that both the healthcare professions and people wanted to be engaged with their electronic health record. However, at a national level, this wasn't happening. So my research found that if you actually invited these people to engage in the development of national strategies and products that are to be used by these people, the uptake and the critical mass would increase at a far greater rate. And that has been found in Australia. So in about 2014, I was invited to be a clinical reference lead, and there are now 47 of us across Australia, all advising the Digital Health Agency in the different pillars which I've just mentioned of the digital health strategy. Most recently, I've been involved in delivering the nursing midwifery, because that's my background, nursing midwifery capability framework. So what we're finding is that the strategy is far more authentic, it's far more real, and is engaged with far more quickly, really. It's in that it's developed from the real world perspective of what it actually means to deliver services, because the people involved actually feel they're being listened to.
Therefore, Helen, when you have engagement, it means that you influence in the way people care in the community. And obviously, you're in a beautiful part of the world. Tasmania look amazing in that background. Therefore, when we talk about remote access, what sort of service, because in Latin America is all this new because of COVID-19, what are the services that scientists like you provide to the community?
So I think even Latin America will realize that telehealth has been around for 20, 30 years, but there hasn't been the uptake in it. Just the same, it has been with the electronic health record and video conferencing. The telephone has always been used for many, many years. Now it is actually the interoperability of the electronic health record, the telehealth products, the telephone, point of care testing. These are all opportunities that are now being really, really challenged, especially in the year of the pandemic. Not a nice name. I prefer the year of the nurse, I have to be honest, but I think 2020 will be known as the year of the pandemic, and most people will realize what we're talking about wherever we are in the world. But now there's this real opportunity to bring all the different technologies from the telephone through to telehealth, through to electronic health records, point of care testing, mobile technologies, wearables, all those things together, and really, really challenge interoperability and interprofessional communication.
Therefore, do you mind to explain in very simple terms? I mean, as you know, you're an expert in the subject. What it means, the interoperability, and why it's so important, because you are very knowledgeable about the impact of having fragmentation. You use this word; it's not really fancy, but it's essential to provide quality of care.
Absolutely. And quite often I find I have to apologize to students and people for being too enthusiastic and using these words. But there is so much work going on in the development of apps, in the development of all the technologies I've just spoken about, that we're not thinking about how they work together and how all the different platforms, how all the different technologies and all the hardware behind the software works together. So in healthcare, all these platforms, as I call them, all these different technologies actually have to talk to each other to be interoperable. They actually have to, all the different codes we use, especially in healthcare, have to be able to talk together. So it's all very well, and I'm being very respectful when I say these words, of inventing an app, inventing a point of care test, and seeing how much money it can make for you. But if it can't talk to other technologies, an electronic health record, an electronic medical record, then it's going to continue the silo delivery of healthcare that I personally rail against and would really like to avoid. As people in healthcare, we should all be working together, whether it's a cardiologist, an endocrinologist, somebody working with the endocrine system, an orthopedic surgeon. It is what we are, one person. It is my health. I am one person with many complex organs working to deliver this one person. I like to be seen as one person. And as such, it's my health, my record, one person. It's all one person. And we should work as one person wherever we are in the world and whatever time of day it is.
Therefore, as person and as the leader and women in technology, Helen, would be interested in how to respect this person for my health. Having health today, it means everything. With COVID-19, if we're sick, we cannot work. If we're sick, we cannot travel. If we're sick, we cannot visit the family. Therefore, yourself as a woman in technology, and as you know, this is actually a summit for millions of people in Latin America. What would be the message for them, especially they have a little bit of a scary situation to bring girls into tech? And as you say many, many times, this is our time. This is the time we have to bring together all the services. But can you tell us your experience as a leader in technology for healthcare?
So from my experience, it's really developed from my belief in being a person and that growing. And I actually developed my nursing skills towards the role of a nurse practitioner in primary care. As I say, I started off as a nurse, but I wanted to know a little bit more about the system and the clinical systems and be able to contribute more independently as a person. That evolved into the use of technology. So basically, as a leader, I very quickly realized that I had to stay at the forefront of everything that was happening. So that included technology, which is where I came. I really never, to be honest, Carol, considered whether I was a woman or not. I'm a person in my right, and I've always been encouraged by my family and by my husband, latterly, that I must follow what I believe in. And equally, when I'm working with people that require healthcare delivery, it's their pathway, it's their health. Therefore, I would never, whether it be a student, a person or a patient in an acute setting, tell them what they have to do. I have the knowledge and I have the skills, and I want to share that knowledge and those skills. How people interpret those or not and take them on board is their decision, but I'm there to offer them. And as a leader, that's what I consider important in my role, that I do have that knowledge and those skills, and please take them from me. I've developed them, but take them from me and learn from them, or not, as a case may be, because we learn every day, Carol, and hey, none of us get it right all the time, and we have to learn to accept that we're not right all the time, and we have to learn to accept that maybe the road we're on isn't the right road, and we have to take the fork in the road and maybe continue on another journey and another choice. And I think throughout my career, I've always been open to, some people call it innovation, other people call it change. It needn't be new. It needn't be anything new, anything groundbreaking. It's a different way of thinking. It's all the information I have isn't mine. It's gained from other leaders. Therefore, it is up to me to share that information. I hope that answers your question.
Oh, definitely. Firstly, for me, it's very refreshing to say that I'm a person. I never realized really it was any differentiating, which is fantastic. We welcome your advice, because as a person, we can get respect, we can get credibility as a scientist, and also some leadership and innovating, as you say, no provoking a high technological robot or something like that. This is about changing your way of thinking. And within that, Helen, it's a lot of uncertainty in Latin America, especially how we're going to get out with innovation. And what is your vision about or how we can get involved with this innovation from home, from the community, from the university? I mean, we got a diversity of women in this summit. I mean, there are 15 countries. We got lawyers, we got nurses, we got doctors, we got homeowners. I mean, definitely it's a diversity of women. Therefore, what advice would you give it for innovation in this reconstruction post-COVID-19?
So post-COVID-19 and in the developing world, I would say the very, very first thing that you ever do with innovation is build trust, is listen, and is to hear what is needed. I am very, very keen on finding out what is needed and really listening to that, and then thinking, fantastic, how can we actually now build on this? So not actually finding the solutions for people. Again, as I've said, we've got the knowledge and the skills and we're there to share them. But we have to listen and build the trust of those people and interpret those knowledge and skills into what is required in those communities. So I come from an English background, living in England, in the north of England. You can tell that by my accent. Most people that are listening to me will be able to tell that I've not got an Australian accent, and I don't have that side. When I moved to Australia in 2004, even though we talk the same language, and I use my fingers like that because honestly, when I first started in Australia, I worked in general practice and I wanted to start at the beginning. Again, following my philosophy of needing to understand what is required before stepping in and saying I know the answers. I worked in a general practice in rural Tasmania. And I found it very interesting on the first day when I went into reception as a nurse to call the first patient through, and I called Andrew. On numerous occasions, I called Andrew, and nobody moved in reception. The receptionist stood up and shouted, "Andrew, the nurse needs you." And this person called Andrew stood up and immediately followed. So even though we speak English in Australia and we speak English in England, they're two different languages. And I think that is a really important message. Listening and hearing. So the way I call Andrew now in reception, or with students is very different from what I would call in North England.
That's wonderful, because you touch a very important concept that is actually changing paradigms about active listening, but about the value of trust. Can you tell us exactly, and obviously you're an expert as well in ethics, what is so important to develop digital health within a digital trust environment to get resilient? It means I've seen your work, and it's very significant because the interpretation you give is not only scientific, but also you provide empathy within that interpretation to the communities. Therefore, Helen, how do we actually implement trust when we're really collapsing as humans at the moment with this pandemic? And trust can build in any space, as I learned from you. Therefore, can you give us some tip about building trust?
Yes, taking time. So I talked about getting to know the person or the patient, depending on which environment you are in, and then getting to know their community. So not just getting to know the person, but getting to know their community and getting to understand them. So very much in my research, when we were working with, in Australia, the electronic health record is called My Health Record. When we were working with that, I'd not used My Health Record either. It was brand new in Australia. I was completely transparent. I might know about health, growing up as a nurse, and I might know about complex chronic disease, but I certainly didn't know about My Health Record. The frustrations for me were as transparent as the frustrations that were for those people registering for My Health Record. It was a very new initiative, and it was so clunky and difficult to register, so many clicks on the computer, that in actual fact, I was able to really, really sympathize and empathize with my participants. So they were so resilient. I actually expected to have a very large attrition rate from my research because My Health Record was so difficult to register for in the first place. And there were so many different levels. Not one participant left me because we worked together. We worked together as individuals in interviews and as focus groups to find our way around the problems, report those problems. And over the year of collecting the data, because it was a research project, we actually saw change in the system because I was reporting it back. So we actually built trust by managing change. So the behaviors of those people who are already very, very, very resilient people with complex chronic diseases living in rural communities who wanted to communicate, they communicate, but they offered to a larger organization. They offered their skills to a national organization, and they so wanted to see me succeed. I'm still in touch with them today. I couldn't have been more grateful to them. And that was by me trusting them that they would see me through this. And they were wonderful.
Therefore, building trust also not is always being positive. It's about reconstructing alternative to then recognize problem or recognize challenge or recognize reality. In that sense, building trust, we talk a lot in healthcare about some of the political decision versus ethical position. Therefore, how do you recommend for women involved in politics? Because we got a lot of the women here, then the mayors and ex-president, we got Nobel Prize as well. Therefore, as a scientist, obviously you're being really consistent in your message through your whole practice. I have the pleasure of working with you 1 year. Therefore, tell us what are really the elements who provide you the quality of service you always have in mind, Helen. I know this because of practice. Therefore, the tip is building trust, have ethical decision. But what will be the third component you will invite women involved in the public arena?
Honesty and transparency would be the two words. It's not expecting everybody to achieve. Not everybody wants to be a leader. Obviously, the people at this conference are all leaders. But that doesn't mean to say everybody wants to be a leader. And I know, Carol, yourself and I have witnessed leaders where we listen to them and actually think they're not really working with the interests of the people. And there are times where that can be frustrating. However, when you're working with students, people, patients, you must remain ethical yourself and be transparent yourself so deliver the story that you know as it is. We know certainly in Victoria, the Premier has really struggled with delivering the message regarding COVID and how we've been managing COVID-19, which when we put it against the rest of the world is probably quite a small problem, but was large for Australia. And the lockdown was certainly significant in Australia, and certainly Victorian Australians weren't that tolerant of it. We have to be honest there, and that's me being honest and transparent about what I actually saw. The Premier, in my mind, could possibly have made more use of his medical directors. He did use them, and Brett Sutton did a good job, and I'm sure those people are exhausted. However, in the first place, the Premier tried to present medical details that he didn't have the clinical skills to do, therefore wasn't able to portray a transparent approach despite his best efforts. That's my gut feeling about that. That is a personal feeling about it. So it's not about leading in every field. It's acknowledging you don't know in some fields, but you will find somebody that does, that might be able to answer your question. So as far as my health record is concerned, in Australia, yes, I know a lot about it. As far as nursing and nurse practitioners across the world are concerned, I know a fair amount, I would say, about those. However, I also acknowledge if you put me into a world of engineering, I would find an expert in that, or a world of gamification, and I would call for an expert, or a world of sensors, I would call for an expert to support me. I would help them translate it into a human-centered approach, but I would never try to say what was working behind the scenes in those things.
That's wonderful, Helen, because in a sense, we need to learn to be honest to ourselves, be transparent with our strength and weakness, as you said. And also, it's very evident through your public speaking when you're being honest with yourself, because as you very well explained in the example of Victoria, it was very evident when you actually see scientific news versus political news and even economical news, because this COVID-19, some people really think that it's all about economy, but really it's not about number. This is about human life. And we got a few minutes left, but Helen, it's been so amazing talking to you. And I'm sure that some of the people in Latin America will send your son emails and content. It would be great. How do they contact you, Helen? Do you prefer to contact through LinkedIn, or how do you actually be publicly available for all the people in Latin America?
So I actually think LinkedIn is the best. I'm on LinkedIn and Twitter, Helen Almond or Helen Mary Almond, for both of those, very easily to contact me through those. And also that lets you have a look at the world I'm engaged in. So the Australasian Institute of Digital Health, and obviously the Australian Digital Health Agency, and the Australian College of Nursing. I think they're the three main bodies that I'm really working with at the moment, as well as Swinburne University of Technology as well. So, you know, those are the opportunities to actually see the world I'm living in at the moment. And also, for those that are interested, engaging in those as well.
Excellent, Helen. Therefore, I will actually send a little message in Spanish to finish this video and beautiful interview. Once it's finished, it will be available. We appear on the 27th of November for all the community Latino America. Muchas gracias a la doctora Helen Almond, con toda su alma nos habló, y por favor no olviden de hacer comunidad, como ella lo dijo, confiar, honestidad, transparencia. Ella es un ejemplo para todas nosotros para que nos inspiren. Thank you very much, Helen. If you want to leave a last message for the whole community, it will be fantastic.
Thank you so much for inviting me to present myself today, I suppose. It's been a wonderful opportunity, and I hope one day we'll be able to meet face to face, and hopefully it's one day soon. But please, in the meantime, take the greatest of care of yourself, and I look forward to you all becoming leaders or developing your leadership roles in future. Take care.
Thank you.
Bye.
Thank you very much, Dr. Helen Almond.